Good afternoon, everyone. Thank you for joining us today for this webinar, Medicaid's Role in Prevention, Population Health, and Building a Culture of Health at the State Level. We're very thrilled to have you here, and we look forward to this conversation about Medicaid in a critical time. If I could have the next slide, please. So today we will be discussing two different reports from the National Academy of Social Insurance and Nemours. The first is a report from a study panel of experts on Medicaid's role in both Medicaid's role as a direct funder of healthcare and also its role in helping support services and programs aimed at promoting prevention and population health. Nemours today is also releasing a series of papers on their research exploring the use of existing Medicaid authority to support state-level approaches that link clinic to community prevention to address chronic diseases. First, I'd like to introduce our speakers for today. If I could have the next slide, please. First, you'll be hearing from Trish Riley, who's the Executive Director of the National Academy for State Health Policy, and she'll be discussing some of the work from the National Academy of Social Insurance Study Panel report. Then we will hear from Debbie Chang, who is the Senior Vice President of Policy and Prevention and the Corporate Officer from Nemours. She will be discussing their research that's being released today on this webinar. And then Shannon McMahon, who is the Deputy Secretary of Healthcare Financing at the Maryland Department of Health and Mental Hygiene, will be discussing a state-based example from the state of Maryland. And then, of course, you're listening to Alexandra Bradley, and I'm the Health Policy Analyst at the National Academy of Social Insurance. So I'm going to pass this, and if I could just go over a few pieces of housekeeping before we get started. This is an entirely web-based interaction. Though you may listen over the phone, there's no way to ask questions over the phone. So please note that there is a chat box in the corner where you can type in any questions, which we will be filtering and passing along to our speakers. The slides and a recording of the webinar will be posted on both the NASHP and the National Academy of Social Insurance websites within the next few days, and you'll receive a link from us via email showing you how to get access to all of the resources, including the two reports that are being discussed today, as well as the recording of the webinar and PDFs of the slides that are being presented. So with that, I will pass the baton on to Trish Riley.
Thanks, Alexandra. I'm really happy to be here, and Alexandra and I have worked very closely along with Debbie Chang and a number of people on NACI's study panel on Medicaid's role in a culture of health. With great support from the Robert Wood Johnson Foundation, the study panel really took on a big question about really what is Medicaid's role in moving the dial on individual and population health. Our work was done before the election, but its administrative proposals, I think, have great credibility and importance as we speak, and we can move on with the slides. We did have a diverse membership. Debbie Chang was one of them, and we decided because of that diversity that we would not make recommendations, but rather list out a series of options that states could pursue. There were 24 members representing Medicaid directors, public health, advocates, health plans, researchers, and I was pleased to be able to co-chair it with Sarah Rosenbaum. So we're just going to quickly highlight some of the study panel proposals. But let me first put this whole conversation in a perspective as we think about Medicaid prevention and a culture of health. Medicaid is, as the next slide shows us, the largest public insurer. It's bigger than Medicare. It has an essential and extraordinarily important role in coverage for low-income and medically vulnerable families. And while it has much press about it that's incorrect, it is in fact a facile program. It accommodates changing needs and can, as a result, accommodate the emerging discussions about the culture of health. When one thinks about Medicaid and public health, you have to think about its extraordinary role in covering people with HIV/AIDS from the earliest days of that illness. Its response to Zika, its response to the Flint water crisis. This is a program that can meet important public health crises. And we recognize in our deliberations that healthcare is really an entry point for more comprehensive responses to address the social determinants of health. That really healthcare is not the answer, but it needs to collaborate better. and that Medicaid is a partner, not a piggy bank. So while some would suggest that Medicaid should simply pay for more social services, the fact is that it has a limited capacity, and we need better ways to coordinate and connect it with other organizations and activities. I won't read all of these 12 administrative options on the next slide, but the first three talk a little bit about federal-state relations. And in this era of discussion about block grants and flexibility to states, with the federal government offering more flexibility to states, we suggested that really that kind of flexibility could be important to advancing prevention and public health. For example, demonstrations could be tested for longer-term savings instead of the 5 years included in most waivers. What about 10 years? Could recognize health-related expenditures as qualified for federal funding and count a broader range of estimated cost offsets when calculating budget neutrality. So rethinking what are the conditions under which waivers are granted for issues around health improvement. We suggested an option to develop federally a fast-track approval process to implement more quickly those promising service delivery transformation models that really advance a culture of health and improve prevention. And importantly, the federal government has an important role for states. If the federal government could better overcome the silos of different eligibility and standards in nutrition, health, housing, social support systems, it would singularly help states better coordinate care at a state and local level. The next slide lists three more of our proposals around behavioral health, data sharing, and improving health of children, which Debbie and Shannon will speak more to. On the next slide, we see additional recommendations, and I want to spend just a little time on A8. Develop and disseminate information on best practices and coverage of comprehensive preventive and primary care for adults. We suggested that the feds could do a guide to Medicaid and community prevention and could really recognize much of the state activity underway. All the health homes, more than half the states have medical homes, which are integrating services of health and social services. Louisiana Medicaid, for example, participates in the HUD Section 811 Project Rental Assistance Program that requires an interagency partnership between the state housing, Medicaid, and Health and Human Services agencies, and provides really a formal structure for agencies to collaborate on identifying and reaching out to target populations and assuring that appropriate services are available to residents. In Texas, the STAR Plus program contracts with managed care organizations to serve individuals with disabilities, including outreach to homeless members and coordination with housing services. And across the country, we see states incorporating accountable communities for health into Medicaid transformation to foster multi-sector partnerships and engage in population-based prevention strategies. So you see activities across the country that could be replicated and could be better supported federally. And finally, the notion of disseminating social determinant screening tools that could be used in managed care and integrated delivery systems, and continuing the work on payment methods that really restructure and foster comprehensive care and the integration of health and social services. We had three more recommendations, some of which may not be quite appropriate, A10 through 12 on the next slide, given the conversations in which we are now engaged federally. But one, importantly, suggested developing safety net healthcare payment reform models to promote access, quality, efficiency, and a culture of health, and to really assure that there's coordination and connection between health and medical services. So in a nutshell, that very quickly summarizes the work of an extraordinary group of people and a great commitment by the National Academy for Social Insurance, and I think sets the stage for the work that Debbie Chang and Shannon McMahon will discuss.
Great. Thank you very much, Trish, for that presentation and that overview of the Academy's Study Panel project. I'm now going to introduce Debbie Chang from Nemours, who's going to speak on their project, which included several resources for states. So, and as a quick reminder before I let Debbie jump in, Please remember that if you have any questions for the speakers, you can type them into the chat box, and we will be filtering through them and passing them along to the speakers at the end. So please bring in your questions whenever you have them, and we're ready for you. Great. Thanks so much. Debbie, on to you.
Good afternoon. I want to thank you for that opening and for the honor of being on the National Academy of Social Insurance panel that Trish just spoke about. And it's great to be on a panel with Trish again and with Shannon. I'm thrilled to be here to discuss our work on understanding the options under current law, under Medicaid, to pursue prevention. And I'm going to do three things. I'm going to describe the project and the toolkit that we developed and its rationale, and then go into more details about the roadmap that we developed. It was a roadmap of Medicaid prevention pathways, and provide some specific examples, really speak to the point that Trish just identified, the need for best practices. And then finally, I'm going to talk about what we discovered about how. You know, what were the accelerators, what were the barriers, and what were the lessons learned in terms of Medicaid paying for prevention. Before I do that, a little bit about Nemours. We're a children's health system that decided 13 years ago to go beyond our medical walls to address the social determinants. And while we provide services in the Delaware Valley and northern central Florida, we have a national office with the goal of spreading and scaling what works, especially in the area of prevention. Medicaid, at its essence, it provides clinical services to individuals. And so next slide, and another slide as well. Next slide. And I make this point because in moving to prevention, it really requires a mindset shift. And it's similar to what I have on the slide here. We're moving from a focus on biomedical to a focus on a multifaceted view of health, from a focus on acute, episodic, to a focus on chronic disease prevention and management. And then very importantly, a focus on individuals to more of a focus on communities and populations, from a focus on cure to a focus on prevention, from a focus on disease to a focus on health and well-being. Next slide, and then one other slide. And so our project, we were grateful to have funding from the Robert Wood Johnson Foundation for 1 year to create a roadmap and both explore and identify options. And what we found is there is a tremendous amount of flexibility under current law, and really reinforces what Trish just talked about, the facile nature of the Medicaid program. What we did was the roadmap demonstrates how states and managed care can cover prevention, including obesity prevention. We look at what is can be covered upstream, beyond care in the traditional setting. We identified the range of specific authorities used to support existing programs, and we looked at both fee-for-service and managed care. And we identified the strategies, the how-tos, to implement, support, sustain, and scale up these programs. The next slide, this is an important slide because it tells you the resources, slide 20. It tells you the resources that we developed in our toolkit. We have a roadmap of Medicaid prevention pathways and a set of planning tools. Those planning tools include the list of all authorities that relate to prevention. There's a state planning tool. There's a matrix that shows the examples. We came up with 40 examples, and it also provides links to the authority, to the state plan amendments, and other important information. We also did a white paper that synthesizes the accelerators, barriers, and lessons learned. We also did 3 case studies, which will be posted on the National Academy of Medicine's Roundtable on Population Health Perspectives website. One of those case studies was a nationwide children's hospital, an ACO, going upstream to address population health. And we have 2 case studies, one of Washington State, where they are improving population health and individual health through health systems transformation. And then we highlighted in Oregon their exemplary partnership between Medicaid and public health. So this is the first time that we're releasing these tools to the public. And these will be available on the website you see there, movinghealthcareupstream.org. They're actually available now. To access that, however, you do need to use Google Chrome because there can be issues when you view it through other web browsers. And when you go to the website, we encourage you to register on the site and sign up for the newsletter, and you'll get more information about the tools. In the next slide is about the tool, about the roadmap itself. Our goal was to provide options for states that are considering using Medicaid to support prevention. And so we uncovered 40 on-the-ground examples from 23 states. We also have hypothetical examples of what we believe is permissible under current Medicaid and CHIP authority. To organize what we found, we developed 5 categories along a continuum of programs focused on individuals to groups of people or geographic regions. Again, since Medicaid provides services to individuals, not generally groups of populations, or geographic populations, we really focused on individuals and then move up to population. And as I said earlier, when we identify examples, we also put a reference or a link to the Medicaid Authority used, the CMS-approved state plan amendment and waivers and other background information so that it's really easy for states to click and find information on various ideas that you want to try. The next slide, I'm not going to go through this. It's a range of the Medicaid authorities under current law that relate to prevention. And then the next slide, the next 5 slides, I'm going to go through the roadmap and the 5 categories. So this very first category is kind of traditional, where you have a traditional provider like a physician or a licensed practitioner that provides a preventive service to an individual Medicaid enrollee, generally in the typical medical setting. And the example given here is in Oklahoma, the Medicaid program reimburses for health and behavior CPT codes delivered by mental health providers for a primarily medical weight-related diagnosis. Next slide. Here's the same kind of traditional focus. However, the provider takes an added step of referring the enrollee to a community-based organization for additional non-medical supportive and upstream services. Again, we have an example here from Missouri where there is a multidisciplinary weight management program that refers to big brothers and big sisters and also to a parenting program. And the program first focuses on families' basic needs, housing, transportation, and safety, before weight loss. So it's a good example of making that connection from clinic to community and even providing some non-medical benefits. In the next example, next slide, we're looking at providing to, again, an individual enrollee, but a preventive service in a non-traditional way. By that I mean through a community health worker, so a non-traditional provider, a non-traditional setting like a school or child care or community or home. And by non-traditional I mean more of an upstream benefit or a benefit that's a non-medical service. And the example we give here is in Ohio with Nationwide Children's Hospital, providing care to schools and communities, so that non-traditional setting, and providing it through a non-traditional provider, through behavioral health counselors. So the next 2 are focused much more at the population level. Here is where there's a population intervention provided to an entire community or geographic region rather than to a specific individual. And so the intervention is not limited to patients of a particular practice or enrollees in an MCO. It's really paying for a service even though it's not provided, not provided to a Medicaid enrollee, but to non-Medicaid enrollees. And so in this example, in Massachusetts, the state uses administrative CHIP funds to cover 9 public health programs related to improving the health of all children and providing, for example, youth violence prevention and young parent support. In the final category, it's a population health intervention in which Medicaid and another state agency or department share goals for a population in a geographic region and collaborate as partners. In this example, in Oregon, Oregon is aligning its healthcare and early learning systems all around kindergarten readiness. And in Oregon, they have community care organizations paid by Medicaid. And one of these organizations is HealthShare that operates in Portland. They meet monthly with the 3 early learning hubs in their region to discuss joint initiatives and align their work. And again, there are additional examples in all of this, and you can see those examples in the roadmap appendix, the matrix that I mentioned earlier. So now in this next section, next slide, I'm going to go through the accelerators, barriers, and lessons learned. So in terms of accelerators, I'm not going to go through all of them, but certainly having a high-level champion, whether it's former Governor Kitzhaber in Oregon or Marianne Lindblad in Washington, or Shannon in Maryland, who you're here next. Having that champion is a key accelerator to this kind of change. In addition, the state Medicaid program, or the MCO, could play a role as a convening entity, partnering with different stakeholders in the community, for example. Also, we found that there tended to be more success when a program thought about long-term sustainability at the beginning, not at the end, and had long-term population health goals. Also, another success factor was infrastructure. If there was an infrastructure that encouraged interagency and cross-sector collaboration, so for example, in Oregon, there is a lot of cross-sector collaboration. There's even a person that was on staff whose responsibility it was to have that coordination between Medicaid and public health. So those are examples of facilitators. In terms of barriers, the 4 that I want to highlight here is, of course, taking on population health requires a change in how Medicaid provides care. We've talked about that. So things like investing in non-traditional providers, for example, that's a difference in how to provide care. Another barrier really is the inability to demonstrate ROI for prevention. We have found has been a barrier to states and managed care plans in adopting prevention. And also prevention tends to have a longer-term benefit, and lots of people are looking for that short-term benefit. So a way to address this is to take a portfolio approach to address both short-term and longer-term issues. Another barrier is when there's no established interagency collaboration, but that's easily overcome by creating work groups and working in collaboration. And finally, in the managed care realm, there are concerns about the medical loss ratios, because medical loss ratios at this point, the population health services qualify as administrative costs, and so they lower the medical loss ratio, and that creates a disincentive. Now, in the state of Oregon, they've actually changed their rules to allow population health to be classified as medical services. So those are ways to address some of those barriers. And then the next slide after the next one, so 2 slides over. In terms of lessons learned, I'm just going to summarize 4, and that is that obviously leadership is critical. And another thing that's critical is thinking long-term from the start. What are your goals and objectives in the long run? How are you going to sustain the program? We talked a little bit about collaboration. That's key in terms of working with. There are things that the managed care plans and providers and states can do, but in collaboration with others in the community, that's the best way to accomplish the goals. And finally, this relates to that comment that taking a bottoms-up approach, targeting services to the community, working with the communities to understand what are the needs. So those are 5 key lessons learned. And then finally, to tee up what Shannon's going to present, we were fortunate enough through Academy Health, which is also funded by Robert Wood Johnson Foundation, to have a second phase of our project. We are testing and are going to be sharing Medicaid approaches to financing upstream prevention in 3 states. We're fortunate to work with Shannon in Maryland, and she's going to talk next about the great things she's planning to do. And we're working with the Medicaid director and a CCO in Oregon, and working with Marianne Lindblad in Washington State. So we'll have 3 pilots. And our main deliverables from this pilot are 2 things. One is a how-to guide to really work with these 3 states and really identify, what works in terms of implementing these types of programs, and then most importantly, to get that out to the field. And secondly, we're really going to be focused on these payment strategies. And really through, learning by doing these pilots, we're going to learn a lot about what works under Medicaid for financing prevention. So with that, I want to thank you for having me a part of the panel, and I'll be happy to answer questions. And I'm going to turn it over to Shannon.
Great. Good afternoon, everybody. This is Shannon McMahon. I'm the Deputy Secretary for Healthcare Financing at the Maryland Department of Health and Mental Hygiene. And in that role, I serve as Maryland's Medicaid Director. Thank you to the team from NASHP for having me on this call. I also want to thank the folks, obviously, at Nemours, Debbie and her team, and Debbie also a proud alumni, having sat in the same chair I'm sitting in a few years back, and then also Academy Health for all of their work. And I would be remiss if I didn't thank the Horizon Foundation, who is actually funding some of the on-the-ground work that we're doing on this initiative. They are the largest health philanthropy in Maryland and have been spending a lot of time thinking about childhood obesity and the impact both in the local community where they work, which is Howard County, Maryland, but also statewide. So thank you to all of them. So a little bit about us on the next slide and our big picture prevention strategies. So we, like many states, have a very robust EPSDT program, have great collaboration at DHMH. Our colleagues in public health are either next door or down the hall, and so we have the great fortune of having the leaders of those areas reporting to the same secretary, and so we can have our priorities aligned. So we work really closely with our partners inside the agency in public health, as well as with the academic community and the physician and provider community. We also work really closely to make sure that our periodicity schedule aligns with that of the American Academy of Pediatrics, and have pediatricians that actually are on staff here and deeply engaged in the work on EPSDT. One of the other big strategies that, as we were looking at the access and the utilization of dietary counseling for kids, we realized that our Medicaid state plan didn't allow for payment of group counseling, and so one of the changes we put in and got approval of January 1st, 2017 was to allow Medicaid to pay not just for individual nutritional counseling, but also group counseling, and that change is an important little nuance that leads into the initiative that we're working very closely with the Nemours team and the Horizon Foundation team to try to test. So the next slide gives you a little bit of an overview of what we're doing and how we're trying to do it. So we are trying to promote both healthy eating habits and obesity prevention, and to do it in much more of an upstream way. And then to figure out the possibility of how Medicaid payment for these activities, and in particular in this case in Head Start centers, might be a viable tool to use as a front-end strategy of really meeting people where they are. Debbie did a nice job of talking about social determinants, how it informed the work that they were working on with the Academy. And I think it's an important piece that our stakeholders have been pushing us on, and is part of what we're trying to test here with the Nemours project. So the next slide talks about the 5 elements of what we're doing. So first, working closely with Debbie and her team, trying to research, develop, and test payment models for social determinants of health. And so if you look at that roadmap that is guiding this project, we're trying to really get people connected to non-medical upstream services. And then we're trying to identify pathways for Medicaid to figure out the idea of how Medicaid could pay for dietary counseling in a Head Start environment. So really what we're doing there is trying to run data about the kids who are participating in Head Start, who their Medicaid managed care organization is, whether or not they've been referred by their pediatrician to nutritional counseling, and try to get all of that information together to make it possible for and to candidly make it financially viable for a nutritionist to work with Head Start programs and bill Medicaid if they're doing a weekly or daily or monthly preventative service in the Head Start environment, whether that's grabbing parents and doing a 30-minute counseling session before their kids start school, after school, but really trying to think about how we can meet people where they are and use Medicaid as a potential financing mechanism for that. So the next slide talks particularly about number 3, about what I just talked about. So trying to do that population level intervention that would support people who are both in Medicaid and are outside of Medicaid. So, if it's financially viable for a nutritionist to provide that counseling, and bill Medicaid for the 8 or 10 members that are in there, could they also either do it gratis for people who are not in Medicaid or bill private insurance for individuals who have private insurance who have children participating in the Head Start programs. And then the other area of interest, in particular interest of our colleagues at the Horizon Foundation, was trying to figure out how the federal Eat, Play, Grow curriculum that's used in Head Start centers and Bright Futures guidelines could come together and also inform future interventions in Head Start environments. So last but not least, one of the last goal of this project is on the next slide, is to figure out how we can contribute to the business case for states about whether or not this is a viable alternative. And this is really where the rubber is going to meet the road in terms of that engagement with the managed care organizations. It's making sure that it's technically possible for providers to enroll in a managed care organization, how to help them with the administrative issues associated with billing multiple managed care organizations, getting themselves credentialed, and moving between sites. There are many areas where some of the Head Start programs have multiple sites. So how can we make it a worthwhile venture for them from a financial perspective, from a logistical perspective, to work with multiple Head Start sites, and also to partner with different providers in the provider community to make those connections, perhaps with FQHCs and other essential community providers that have strong connections to the Medicaid population. So where are we going with this on the next slide? What do we think we're testing, and what are the potential opportunities that we're trying to identify in this project? So first, I mentioned the trying to meet people where they are. So it's your daily sustained connection. Kids are going to Head Start every day. Mom and dad drop them off. How can we grab people where they are and try to address their needs upstream as much as we can, in a setting that's comfortable, familiar, easy for them. Also trying to make those partnerships between our managed care organizations and the Head Start centers. So part of this exercise has been convening some of the medical officers, the chief medical officer in Medicaid, with each other and with the Head Start centers and with the nutritionists to try to honestly get nutritionists outside of the hospital, outside of the office-based setting, and again, get them into the community, meeting people where they are, where kids are, where families are. Obviously leveraging the Head Start infrastructure, both from using this curriculum that's out there that they're already using. How can we leverage that in addition to these individual and group counseling sessions in the Head Start environment? Obviously, we want to push the envelope on our new dietitian group counseling spa. Our physicians, in particular, a couple of our physicians, one of whom is a pediatrician, really felt strongly as she reviewed the evidence, and we're knocking this about among the clinicians and operations folks here in Medicaid. There's great evidence in group counseling, ranging from for kids as well as for adults. I think most of us are familiar with Weight Watchers, so thinking about it through that lens a little bit more, and trying to push the envelope as much as we can to utilize that new flexibility that we have in our state plan. And then last but not least, really think about what the opportunity is, the win-win opportunity is for our MCOs down the line. They have, specific value-based purchasing goals that they have to meet for childhood wellness, for visits, immunization schedules, things like that. So where's the opportunity for them to make better connections with their members and to get people into more upstream services and think about things from more of a prevention lens than a reactive lens. So that covers my overview. We're really excited. We are engaged in this effort. Will be for the next 6 months or so, and really appreciate all of the efforts of Debbie and her team and the Academy Health folks and Horizon for candidly pushing us into this and to nudging us and supporting us as we move this along. So more to come. Happy to share where we go as this project happens. And I think at this point I'm going to hand it back over to the NACI team for questions and engagement with everybody who's listening.
Great. Thank you so much, Shannon. That was excellent from everyone, and it seems like a few questions are trickling in, so I'm going to start with one for Debbie. We had, what is the timeline for phase 2 of the project, and is there a way for state consumer advocates and their networks to get engaged in identifying strategies that work?
So the timeline for the phase 2 project is, it started in January to actually end of September. So it's really only another 6 or 7 months. It's a short-term project. Having said that, we'd love to hear from others who are in the field working on this. So by all means, my email I think is somewhere in the documents. So we'd love to hear from you because, in each of the sites that we're working, it's all about, partnerships.
Absolutely. Partnerships are critical in this kind of work, especially with Medicaid. So one question that I had for all the speakers, I think something that may be on the minds of our attendees is kind of this environment of a possibly highly tightened budgetary restriction for states working with Medicaid. And so how can states be encouraged in that context, even with tightened budgets and lower federal dollars, to continue to innovate towards improving the social determinants of health?
Well, given the current budget constraints, I think there's no better time than to invest in prevention and population health. There are both short-term gains when you look at things like asthma or other chronic diseases, but then there's long-term gains when you look at issues like obesity prevention. I think we're still to Shannon's point, we're still building the ROI for this work, but there have been some successes in the state of Oregon. They had a 5-year waiver. Part of it was to get some funding up front for their transformational proposal. They are starting to show savings in, I think, year 3 already. So that's an example of, a comprehensive proposal that involves population health and integration with clinical care, and shows a reduction in costs.
Excellent. I don't know. Did any of the
Yep.
Yeah.
I think it's a more than legitimate question in a time of great uncertainty. And Debbie makes an important point, but it does become very difficult when dollars are tight to make the case to governors and legislators and budget officers. So the ROI piece is terribly important, and Debbie and Shannon's work is critical to that. But it's also a very important issue about collaboration and working more collaboratively with different agencies to get it right. When you think about health and housing and the resources that even in an environment of less resources that are available through other agencies, how we can sort of better integrate those, standardize eligibility, standardize reporting requirements that both save money and build efficiencies, makes sense and really needs to be done.
This is Shannon. The only other thing I was going to add to this is, I think one of the things that we've really stressed on this is that it's a win-win for the MCOs too. Right now, I think they don't see high utilization of nutritionists in their network, and it's because many of them here in Maryland are hospital-based. So they're enrolled providers, the MCOs are doing their job of making sure they have a robust network, but they're not in an environment where you're going to conveniently reach people. And I think that's one of the things that's really, really compelling about what we're trying to do here. And so I concur wholeheartedly with what Debbie and Trish said about the ROI models. We're in uncertain times, and all the more reason for us to be thinking about how we can leverage, group counseling opportunities versus, individual counseling, which appears to be hard for people to reach. So, ideally, if there's going to be big change takes time, and we'll have time to work through and understand the ROI models of initiatives like this before those big financial and coverage changes roll into effect.
Thank you, everyone. Those were all great answers. And kind of to piggyback off of that, this question comes both from myself and one of the audience members. Can you all speak to ways that other sectors such as education or housing can get engaged in population health? And on that front, how might states potentially involve those other sectors in computing the ROI on a program? So say if you had a population health program that maybe was executed through Medicaid, but it saved money in the housing dollars or in nutrition dollars or in some other sense, how can we kind of bring all those other sectors into the game of promoting population health?
I'll take a first crack. I think there's some great examples in Louisiana, in Texas, and California of doing just that. I think one of the challenges is that the federal government has a fairly narrow view of what counts in budget neutrality when determining waivers. When you seek a Medicaid waiver, you need to prove that it won't spend any more money than would otherwise have been spent. So one of the proposals from the work group was, what if the federal government took into account potential savings in education and housing and other programs? And I think that this administration might be open to that kind of flexibility.
Thank you, Trish. Yeah, that's a great point about the study panel report. Debbie or Shannon, did you have anything to add on either that or how other sectors can get involved in the population health effort?
Just one thing to add to what Trish was saying. I agree completely, and that the other thing is to look over a longer-term time frame. The budget window right now for 1115 waivers is 5 years, which is a long time. However, when you're looking at prevention, it's going to be some of the savings will happen, more in a longer term. So I think that's another area for possible flexibility. In terms of engagement with other sectors, I think that there are so many examples, as Trish alluded to, of states that have reached out and worked with various partners. In Washington State, they ended up convening a group of stakeholders in developing the governor's overall transformation plan. Stakeholders were obviously involved in Oregon. Certainly, Shannon in her example, working with Head Start centers and with a local foundation. So I think that it really takes somebody reaching. The first step is reaching out and trying to break down those silos. The other thing I think is important that Trish mentioned in her opening is she had the little point that said Medicaid is not a piggy bank. And so I think it's important that when anyone comes to the table that it's a partnership. There's a role for Medicaid, there's a role for the community stakeholder or that sector. And so coming to the table with that spirit is, I think, going to foster better collaboration.
Great. Thank you, Debbie. And Shannon, do you have anything to add there?
I would just say we really spent a lot of time thinking about the social determinants issues when we were seeking our 1115 waiver renewal. It was actually just about this time last year, which was approved in December, and we have included in that waiver two key things, which is housing support services, so 2 pilot projects. And again, in many ways, this is the proof of concept, right? So if you build it, will they come? engaging with our local partners to do more home visiting for kids under 2 and moms, and so trying to, again, meet our local partners who are doing some of this work, local public population health-based work, and saying to them, how can we, as Medicaid, come to the table and support you on that? And then on the housing support side, recognizing that we had a lot of, in the midst of an opioid crisis, how can we do things to get people to stay stable, stay in their housing, become good tenants, things like that, because there's clearly an ROI for Medicaid on that. And so those are 2 pilots that we're deeply engaged in. And to both Debbie and Tricia's point, it has required us to kind of reach out of the building where we are in Medicaid and engage with our partners in housing, engage with the local health departments. And again, just to reiterate how lucky we are in Maryland to have our public health agency and Medicaid in the same place. There's a very healthy tug of war and pushing and pulling that happens that I think very often results in good outcomes and programmatic initiatives to address population health.
And there are documents on the NASHB website. Look for work by Amy Clary that go into greater detail, but certainly, as Shannon knows, the state housing finance agencies need to create plans and priorities to qualify for federal funding, and they can establish those plans and priorities to require linkages to health agencies and priorities around the same priorities that Medicaid has.
Great, and yeah, this is actually reflecting a lot of the questions which are coming in, especially one in regards to how it might be possible to better align, or if it might make things easier for Medicaid if the administration of financing for healthcare is better unified, such as across children's healthcare, so Medicaid, CHIP, children needs or special healthcare needs, if the funding for those things were aligned more readily. Are there things that states are doing that facilitate that alignment in terms of financing across those programs? And also another attendee mentioned public health and aligning public health organizations with Medicaid. So can you speak to that at all?
Yeah, there's a lot of examples of, we found a lot of examples of states that have a long tradition of collaborating with public health. Massachusetts is a good example of that. And I mentioned earlier Oregon and Washington State. In Oregon, we did a case study on the Oregon as an example of a state where, you know, there's been a long-standing collaboration between public health and Medicaid, and you know that happened over time. But it began with the first step, you know, a first point of collaboration. So, you know, I think there are a number of different examples where that has happened. And if it isn't happening in a particular state, as we pointed out in our work, establishing some type of coalition or a work group to bring together various folks is either to design a program or around some shared goals, you know, where there's buy-in. I think the buy-in is really important, that you know, it's kind of co-developing and co-designing something. I think that's really important to success in these types of programs.
And I think there is increasing focus on payment and delivery system reform that embraces population-based activities like the Oregon, and we talk a lot about the Oregon Coordinated Care Organizations, but they now have flexible services to meet, you know, health-related needs. They can even provide temporary housing during post-surgery. And you see in the medical homes some enhanced payment for primary care to connect with social determinants, and the accountable communities have been good examples of what Debbie was just talking about, that you've got to get everybody at the table to figure it out from the get-go. And Washington, with their 9 accountable communities, include the State Healthcare Authority, the Department of Health, the Department of Social and Health Services. Many of these are funded by SIM grants, federal grants. We're not sure where the future of those will be, system innovation initiatives. But in Washington, every accountable community identifies regional health priorities, and they're really required to talk about health improvements, housing, food security, economic and educational opportunities, and health equity. California is doing something similar with their accountable communities, where the communities have to choose a health need or a community to focus on, and they must partner with cross-sector entities. So I think there are real examples. They're emerging and relatively nascent, but really important to watch.
Yeah, I just want to add to what Tricia's saying, that there's a lot of innovation happening now on this, and so I think we're going to learn a lot in the next couple of years in particular.
Absolutely, and it's something I feel like a refrain of these projects has been how much opportunity there already is for innovation and how much can already be done on the level of flexibility for states. And Trish, I think what you were just discussing, and also Debbie, in terms of getting all these different stakeholders together in the same room is really in large part what these two projects embody, bringing a lot of different stakeholders to the table. So I encourage all the audience to check out the resources because they absolutely bring all of these voices to the table and make sure that we are looking at different interests and different needs and different approaches to promoting population health. So on that note, kind of going a little bit in the opposite direction, Debbie, a question for you, and also for others if they feel up to it. Can you talk a little bit more about champions and how we can identify people who may serve as champions in building up these kind of innovations, and how to recruit them, and also how to facilitate and foster their participation?
Yeah, that was one of our findings in terms of accelerators for moving upstream, especially under Medicaid, was having that champion. I think one point to make is that I think the champions can happen at every level, right? There's, in Oregon, of course, there was former Governor Kitzhaber. In Washington State, there's Marianne Lindeblad, and there's Shannon in Maryland at the Medicaid director level. And even at in Oklahoma, for example, there's a person there who's very passionate about health and public health and Medicaid. And so for years she's been working on this. And so I think this concept of champions can happen at every level. And the issue is, to the point of the question, is finding those people and helping to support them and lifting them up. What we're trying to do in this work, because it was over a year period, so it was a lot of work in a short amount of time, so we're very tired. But in that, we found that there's a lot of examples of folks that are in the field doing this great work, and so what we were trying to do was lift up their stories, by finding these examples. And our hope is that by finding these examples, it will help encourage others who are in the same situation, who can then be lifted up, and they can see that there's a way of doing this. So I think part of it is to get the right information in the right hands. And that's why we hope this toolkit that we've developed can provide that information to somebody so that they can show their boss, that this is something that's happening in these other states, and we want to try it here. It can be done. Here are some of the results. I think those are the ways that you can help to lift up and support those champions by giving them information and by supporting them.
That's great, Debbie. Thank you. And Tricia or Shannon, do you have anything to add?
Debbie nailed it.
I agree wholeheartedly, and I think as the Medicaid director, I think it's important for speaking to the external folks who are trying to grab me as the champion. I think I need to see the business case. I need to know the ROI. I need to know the opportunity. And in this particular case, we're lucky enough to have philanthropy funding the test. And so, to the philanthropers listening to this webinar, I would say, this is a great opportunity to test ROIs, and now could not be a better time than for states to try to jump in on these kinds of efforts, as we talked about earlier. And then the other thing I would say is, I think bringing in the key players and bringing them together and being a convener and a nudger helps. It helps. There's no question about it.
Great. And Shannon, while I have you, we have a question from the audience. A lot of your conversation discussed nutrition and dietitians, but is there any focus on exercise, such as things like kids biking to school or physical activity programs?
So that's part of the Eat, Play, Grow curriculum, and that's why our colleagues at the Horizon Foundation were sort of nudging us on this, not just on the sort of what I would describe as more of the clinical intervention, but also thinking about how we could imbue the Eat, Play, Grow curriculum in what some of the nutritionists are doing for their group counseling visits, and then thinking about whether or not that's something down the line that could be a Medicaid billable service.
Perfect. Thank you. And I just want to remind everybody who's listening in, if you have questions, please continue to type them in. We are still getting them, so feel free to continue to send us questions our way. Another question from the audience is asking about the distinction between for-profit providers and traditional not-for-profit providers and how they can be involved in this innovation in the Medicaid space.
This is Shannon. I don't know that we've, in our particular intervention, I don't know that we've thought really much through the lens of who's not-for-profit, who's for-profit. Certainly, some of our MCOs and the MCOs that are involved in this test are for-profit entities, and some of the Head Start providers are not-for-profit entities, and so partnering them up, I think, is part of this. Some of it's the speed dating, matched marriage, whatever colloquialism you want to use, but trying to get those partners together, whether it's, with using a champion like me, using the payment lever, et cetera, has really been the focus of what we've been doing. So I haven't thought about it much through the for-profit, not-for-profit lens.
That's understandable. Trish or Debbie, I'm going to assume a pass here. So one question that I had for the three of you is, outside of the upper level champions and stakeholders like you, Shannon, or Marianne Lindeblad in Washington, how can the needs of the community that may not necessarily be obvious up front but may be affecting the social determinants of health be taken into consideration? What are some of the ways that Medicaid and these programs are kind of feeling the pulse of the communities and understanding where the greatest needs are, and how can we better facilitate that through Medicaid?
I think one emerging model, and it still is a struggle about reimbursement and how to embrace it, but the notion of community health workers that are indigenous to a community, known and trusted in a community, and who really help with that liaison and connection is a really important vehicle that several states are deeply engaged in.
Yeah, if I could build on that, in work that we did in Delaware in the Nemours Children's Health System, we used, as a part of a CMMI innovation grant that we had, we used community health workers, and these were people in the community that we then worked with them. They were part of our team, of our primary care doc and the various people on that team. And what they did is they went to the homes. So the child had asthma, they would, of course, with permission, work with the family and go to their homes to understand what was causing these asthma triggers. I think it's really, as Trish said, it's a really promising idea, and actually throughout the programs that we identified, this use of kind of community health workers was a common theme. It does present itself. It can present itself as a challenge, though, to a Medicaid director, because then they still need to be certified through some process, and so there's, I think that creates additional hurdle for it to happen. But I think that's one way of reaching the community. I think the other thing is, what we're finding is that in some cases, the Medicaid director or the Medicaid staff, they're really reaching out to community-based organizations who have, ties into the community. And to something that Shannon said earlier, it requires going outside of your four walls, to the community and really trying to understand what's going on and what's happening. And I think with the focus on population health in many communities, it's really starting to happen. There's more of a interaction and coordination between the healthcare sector and, community-based organizations generally.
Absolutely. That's a critical point about community health workers and just getting beyond those four walls and kind of remembering to go back to the roots of who the program is serving and really where we can help the most and where their needs are. We have one specific question from the audience for Shannon. Can you distinguish between references to nutritionists and dietitians? In your presentation, you mentioned nutritionists, and in the slide deck, it said dietitians.
It is dietitians. It's dietitians.
Dietitians.
Yep.
Thank you. Okay, that was just one very particular question. Okay, one more question just popped in. Are there opportunities beyond Medicaid recipients who could generate savings for population health that could be invested in the community infrastructure?
Can you say the question one more time? I just want to make sure I'm following.
Yeah.
Absolutely. Are there opportunities beyond Medicaid recipients who could generate savings for population health that could be invested in the community infrastructure? My guess is other populations besides Medicaid recipients.
Yes, the answer to that. I mean, the area of population health applies to, to all participants in the healthcare system. And in fact, I think what we envision, and certainly what Robert Wood Johnson envisions, is a culture of health which includes both healthcare and population health working in tandem to support a family's, a child's, a person's overall health and well-being. So it applies to across the board. I think that might have been the question.
That sounds like an answer to that question to me. Trish or Shannon, anything to add?
No,
I think that was perfect.
Fantastic. And once again, I encourage folks, if they have more questions, so please continue to send them in. We have had some great ones so far. So Trish, can you just, and actually we had a recommendation in the study panel report that addressed that issue of maybe using group opportunities that didn't apply necessarily exclusively to Medicaid recipients, but may have included Medicaid recipients. Can you discuss that recommendation a little bit more, that policy option a little more, and how you've seen that?
I actually think Shannon mentioned that. It's basically allowing Medicaid to reimburse for group activities where people may not be Medicaid beneficiaries. Medicaid has always been restricted to the individual who is eligible.
Right.
And Shannon, I think you said you were doing some of that.
No, that's part of the test. So we're thinking about whether or not that's something that could be done down the line. So if there's, a group that's meeting, how could we make it administratively possible for the dietitian to bill Medicaid, potentially bill private insurance, and to even have external folks who are neither commercially insured or on Medicaid participate. So that's part of the sort of potential future state that we're looking at.
And the flip side of that, as a old Medicaid director, is it raises costs, and it raises costs for populations that are not exclusively Medicaid. So it raises lots of policy questions, but there may be new opportunities in this new environment of flexibility to test it, as Shannon's proposing to do.
I would add though that when you've got a group visit, there's kind of a sunk cost already. So adding another person, the incremental cost of another person is probably, not a lot. And so I think that might be some of the theory here, right? Because you have sunk costs, you have the person is there providing the details of the visit, and so you just add one other person. It's not going to, the incremental costs really go down.
Absolutely. So the question came in that I've been anticipating getting, and we did discuss a little bit earlier how in this time of budgetary constraints, these efforts might be even more critical, but the direct question came in, how might turning Medicaid into a per capita cap affect these efforts? And I think there are still things to consider aside from the budget savings opportunities. Part of it is also getting people on board to remember that social determinants are important. But can you speak more to what a per capita cap might do to affect these efforts to innovate and affect population health?
Well, on the one hand, the proposal is it gives states flexibility, but the American Health Care Act is not yet clear about what that flexibility will be. There's been some encouragement from Seema Verma about flexibility, but we don't know the details of what exactly states would be able to be flexible about. And the flip side of that would be, can they afford it? Because as the CBO has estimated, it's a 25% cut in federal funding for the Medicaid program. So states really have to weigh, is there so much flexibility, can they make so much savings in the program that they can redirect it and restructure it? Now, I suppose you could also argue that when states receive that much less federal funding, they have that much less obligation for state matching funding. So it could potentially free up state dollars that could be used for some of these purposes.
Thanks, Trish. Debbie or Shannon, anything to add?
No, I think Trish did a great job of covering it.
Yeah, I do too.
Fantastic. Well, it looks like those are all of our questions from the audience. So I'm just going to run through a few quick reminders that these materials will all be emailed to the participants. Anybody listening or registered will get both links to the National Academy of Social Insurance Study Panel Report, which Trish co-chaired, and the Nemours materials, which it says coming late March, but they are actually mostly up today, so you should have access to those once we send the links out. The links will also include PDF copies of the speakers' presentations, and will include a link to the webinar itself. So thank you all for joining us today. This has been excellent. Thank you to the speakers, Trish, Debbie, Shannon. Thank you to NASHP and Nemours for joining us on this event. And we look forward to hearing further discussion with you all in the future. Thank you.
Thank you.
Thanks.